Okay, how often we wonder who decides these NRP guidelines? Okay, so every guidelines is decided by the body, isn't it? So who decides these NRP guidelines? And I think the most of us, the impression is that we copy them from the West, particularly from the United States, because that's a book which we have seen right from the days when we started. Now, please remember that NRP has a program has changed from the time it has started about 20 odd years back, actually, when at least I started learning about 25 years back before that. And please remember the only constant is change. And it's up to us to not to resist change and to embrace it. Because definitely this is one program which is so evidence-based, and it has based on this evidence, the program has developed to such, I mean, such wonderful uh, program. So the neonatal registration program by itself, the guidelines are set up by a body called as the International Liaison Committee on Neonatal on Registration, the Neonatal Task Force, which is actually a body which has 13 countries representing this body. So those are the countries: the American Academy, sorry, Heart Association, the European Registration Council, and so on. So they what basically they do is they collect all the data which has been published on neonatal registration over the past 5 years, and then they go through it in a very strict, structured manner, and then decide on come out with the recommendations. The seventh edition of the IAP, the AAP neonatal registration book is based on the 2015 guidelines, and now in 2020 that has been adopted. They have come out with a new set of guidelines, which is still yet to be adopted. And I think by July 2021, American Academy of Pediatrics is going to come up with the 8th edition. And it's not just the American Academy of Pediatrics. Every country which has its own registration guidelines basically follow the recommendation from this ILCOR group. So I'm just going to go through what is pretty much been announced recently, and it's still not gone on to the registration program. And before that, I think we have had a wonderful session so far. I just thought I'll just run through and then do a bit of recap on the program itself and the algorithm. So basically, whenever we call in for registration, we have got three things to do. Start with antenatal counseling, find out who are the team members, have a team briefing, try to allocate their roles, their responsibilities, and do equipment check. By the time we do it, we have the baby is born. Now, when the baby is born, the questions we are going to ask is the baby is a term baby, is a good tone, and the baby is breathing or crying? And the answer is if yes to all those three, and then what all we have to do is leave the baby with the mother. Just don't jump in and then take the baby away from the mother. Deliver the baby onto the mother's abdomen. Keep the baby warm. If necessary, clear out the secretions and dry, and then just see what the baby is doing. If the baby is breathing and is okay, I don't think we need to necessarily take the baby out from the mother and then try to do things which are not necessary. However, if the baby is not crying, has got a poor tone and is just not breathing, then obviously we have to clamp the cord and then cut it and then take the baby away from the mother. Again, we need to warm the baby and maintain the normal temperature. Now, this is the time when we position the airway, clear secretions, dry and stimulate. And then you reassess at the end of 30 seconds. If the baby is apneic or is gasping, or if the heart rate is less than 100, then you go ahead and start positive pressure ventilation. And this is the time we need to consider using a SpO2 monitor, pulse oximeter, and consider using a ECG monitor. However, if the baby is not gasping, he's breathing, but then he's got significant distress, maybe he looks cyanosed, or maybe if the pulse oxygen saturation is less than what is appropriate for the minute of the life, which the guidelines which was given by Dr. Balakrishnan. In that case, we have to consider giving oxygen or CPAP if it's available. And then once the baby is stabilized, we shift the baby to post-state care. And never forget to debrief the team. See, more often than not, we have a tendency to scream at our team members soon when the procedure is going on, when we are resuscitating. But at the end of it, we never go care to tell them what is right and what is wrong. So suppose if after effective positive pressure ventilation, if the heart rate is still less than 100, what do we do? Then that's when we look at if we are giving effective ventilation and take the corrective chest steps, MR SOPA. If necessary, this is the time you may consider intubating or using a laryngeal mask airway. And in spite of that, if the heart rate is less than 60, then start cardiac compressions and obviously do a synchronized PPV. I mean, we have gone away from asynchronous ventilation and cardiac compression. And at this time, we definitely use 100% oxygen and ECG monitor. And if the heart rate is still continues to be less than 60, then definitely use IV adrenaline and consider giving normal saline even after prolonged ventilation, and maybe consider pneumothorax. Now, this is pretty much what we have been taught so far and what we have discussed so far. Now, with regard to the guidelines changes, what has happened? So in 2015, our initial antenatal counseling and the team briefing consists of 4 questions. What is the gestational age? Is the amniotic fluid clear? How many babies? And what are the additional risk factors? Now 220, they removed basically the how many babies and then talked about umbilical cord management plan. Now one word on umbilical cord management plan. Basically what we need is to have delayed cord clamping. Now how long you would delay? Now, minimum of 30 to 60 seconds. Even now, there are big questions about what happens if the baby is flat. Even in flat babies, we could consider. I mean, the research is more in terms of considering to delay at least for a few minutes so that there will be some amount of placental transfusion which happens. So, irrespective of status, definitely consider delaying the cord clamping. And this is something which we have to discuss. And not only that, we have to tell our obstetricians. Invariably, our obstetricians are very keen on clamping the cord soon after delivery. And that is something which we have to tell them. Now, the next thing which we would need to do is about our routine care, the initial steps. Now, in 2020 is what we have been told. Okay, basically we do a warm, take care of the airway, dry and stimulate, and then again reposition the airway. So what are WADA? Warm, airway, dry and stimulate, and then again reposition the airway. Now, but just think about what we do in real life. We never do it actually. When the baby comes, immediately we start wiping, we start drying. So, and then only we really position the airway. And this is the change which has been incorporated. They have become practical. They have said, fine, irrespective of what we teach, this is what is going to do. So, so it makes more sense just to accept and then start with warm, dry, at the same time drying causes stimulation, and then position your airway and clear secretion. Makes life very easy for all of us. Then the next thing is about meconium stain fluid. This is, I mean, again, Dr. Balakrishnan touched about. And what we need to remember is this is not a guideline which has come in 2015. This is a 2010 guideline. And what they said this, maybe non-vigorous babies, you should consider intubating and then ventilating and then doing endotracheal suction. But since then, that has totally been removed away, irrespective of whether it is a sick baby or a baby who is crying. Just don't bother to intubate the child to clear out the meconium from the trachea. What we need to do is clear out as much secretions as possible, whatever meconium is there, from the mouth and then the nose, and then start bag and mask, I mean, effective ventilation, whichever way you use it. Okay, so this is not something new, but unfortunately, even today, we find that people are still trying to intubate and try to do a meconium, suck out the meconium. There is only one indication. If you really think that the airway is blocked because of meconium or some particulate matter, then might be the only indication to intubate and to try to suck. Otherwise, it's not there. Okay. Now, again, way back in 2010, oxygen concentration, regarding oxygen concentration, there was a lot of controversy. And then people said, for term babies, you could try to titrate, whereas in the preterm, try to start on a higher concentration and then try to wean it off. And right now, I think it's very, very clear. Term babies just start only in air. Just don't bother about oxygen. Okay, because the oxygen saturation for a neonate in the, I mean, for a baby in the in utero is only about 60 to 68%. So why are we just trying to boost it up to so high and cause a lot of oxygen-free radical injury? And for free terms, even less than 35 weeks, we need to start at anything, not more, anything less between 21 to 30%, and definitely not more than that. And our guidelines, for giving more oxygen should be decided by our pulse oxygen saturation, and not by, I mean, just like that, give them a huge amount, whack them with a huge amount of oxygen. The next thing is about something which we didn't talk about because it's again gone on into disuse, but something which we have done it long time back is the felt that sustained inflation, that is initial 5 breaths, what you do is you give back for at least 2 to 3 seconds. I mean, your inspiration would be for 2 to 3 seconds, and then allow the baby, and then allow for expiration. So the idea was for 5 sustained inflation breaths to have 2 effective breaths. That was the original idea. But now what has been told is definitely in preterms it is harmful, and it's no point in trying to do sustained inflation. However, for term neonates, still there is not enough evidence whether it's useful or not useful. So they have not made any specific recommendation for term neonates. So if you are somebody who's comfortable using it, do it. But please remember that the pressure which we are delivering is very huge. It can cause significant pneumothorax and lung injury. Again, something which is coming up in a huge way just to deliver CPAP in the delivery room. So 2010 guidelines didn't talk about it, but since then it has come in. And right now, any baby who has got spontaneously breathing with respiratory distress, use CPAP. And the best way to deliver CPAP in a delivery room, it would be to use a TP resuscitator with which allows us to deliver a PEEP. And sorry, the CPAP. And in 2015, what they said was that electronic cardiac monitor is the preferred method for assessing heart rate during cardiac compression. So we are no longer looking at interrupting our resuscitation with auscultation, or we're looking for umbilical arterial pulsations. But 220 guidelines, they made it very clear that even whenever you need an alternative airway, and just not wait till you are going to have cardiac compression. The moment we try to intubate, the moment you try to put a laryngeal mask airway, go ahead and then connect the baby to a ECG monitor, and because this gives us the most accurate measurement of the heart rate. And what is the best way to do? I think we have forgotten the 2-finger technique a long time back, 2010. I just want to reiterate, and that's why I just put it in. So the best way to use to give cardiac compression is definitely the 2-thumb technique and not the 2-finger technique. And there was this question about what is the exact dose of adrenaline to use. Okay, in 2015, we still had a range 0.1 to 0.3 ml per kg of 1 in 10,000 solution. And for endotracheal, it is 0.5 to 1 ml per kg. Now it has been changed. It's 0.2 ml per kg for intravenous or intraosseous route. And endotracheal, you could use it only once, maybe while we are trying to get a venous access, and that would be 1 ml per kg. And what would you do after giving the drug? For intravenous route, you could always use a flush of 0.5 to 1 ml of normal saline, whereas in the 2020 guidelines, it is 3 ml of normal saline to be given as a bolus after giving adrenaline, either in the intravenous or a intraosseous route, and definitely not for an endotracheal route. Now, this was something which Dr. Uma spoke about, that if after 10 minutes of resuscitation, if there is no heart rate, we could consider stopping it. But now the evidence has moved from 10 to 20 minutes. Now they say that, and even at 20 minutes, you consider cessation of respiratory effort, resuscitation effort, and not just discontinue it. Okay, so that definitely the time has gone longer. Now, those are the important recommendations, which all of them which make sense. But let me start with what let me conclude with what I started with initially in the first presentation. We should all consider having some sort of recertification or training every 2 years. Indian Academy of Pediatrics, along with is doing 2 types of program. One is for the basic NRP, which is for everybody who is involved in newborn care. That could be your staff nurse, it could be a nursing assistant, it could be you, it could be anybody, it doesn't matter. Okay, and then it is, and they, in fact, they are coming up with the second edition. So far, we are using the first edition. Now it is coming up with the second edition. And now there is the advanced NRP, which IAP is actually considering doing it free. Even for previously, we are paying about 4,000 rupees. Now that is being done free for life members of IAP. I think we should undergo one of those at least every 2 to 3 years. Now, just to conclude without making more messages, basic NRP is for low risk newborns who are going to be managing the peripheries. Advanced NRP is for high-risk newborns. The key to successful registration is all about anticipation and preparation. I mean, Dr. Prakash shows in those wonderful videos how well they are prepared. And I think that is something which we should adopt at all places. Ultimately, it's all about effective ventilation, and it is the most important step in any neonatal registration. Okay, it's not cardiac compression, it's not adrenaline, it's not bicarb, it's definitely not normal saline. Okay, please remember that advanced resuscitation measures such as cardiac complement medication is rarely needed. So if you have attended 7,000 deliveries, you probably would have done it once. So I think for most of us, it's a matter of maybe 4 or 5 times in our lifetime. So think about it and then try to concentrate on ventilation. Thank you very much for your patient listening. Thank you.
Thank you, Dr. Thiru, for your excellent presentation. Before I am addressing to the chat box, I just put a question to Dr. Thiru. I think, to my knowledge, the 7th edition, we are using it till December 2021. Am I correct?
So actually no, so they said 2022 also. So for after 1 year after they are published, they are going to use, which means till 2022 we are going to use it.
The 8th edition is going to come on June 2021, but implemented by January 2022.
Yes, sir.
All the changes you have already mentioned in the 7th and the 8th edition also. So I congratulate all the 5 speakers for their excellent presentation. And there is, let me see the chat box. Why it is not time?
So there's one question.
Yeah, please, Dr. Ramachandran has asked. 1 minute. Is there any Indian committee of resuscitation?
No, sir, there is not any Indian committee as of now. What they have is actually the Asian committee, which Asian Registration Council, I think. Actually, that's the one which we are following. But the Indian Academy of Pediatrics, as of now, is following what the American Academy of the guidelines from the American Academy of Pediatrics.
Yeah, this NRP is entirely designed by AHP. Then another question from Professor Ramachandran: why preterm FiO2 21 to 30% and not 21%?
Sir, I think the reason is very simple. Most of us have been used to giving 60 to 100%. I mean, in fact, 100% oxygen for preterms. So it has become very difficult for people to take them away from the practice. That's number one reason. And the number two reason is in preterms or bradycardia, the evidence shows that if you use oxygen, definitely the time needed to increase the heart rate is much, much faster. And that is probably the reason why in the first place they were giving a high oxygen rate. So probably the idea would be in case we have a child who is bradycardic, it should be fair enough to give a bit of oxygen, but otherwise I think 21% oxygen should be the standard, gold standard, whether it is preterms or terms.
This is from my own queries. Maybe Dr. Uma can answer to this. There are 3 questions. If there is no chances of survival, whether the resuscitation should be done or initiated, who will make the decision? Number 1. Number 2, good outcome, very unlikely, where the parents has the decision or the clinician has to make a decision to stop resuscitation. And if the good outcome is considered likely, what is the role of clinician in making a decision to stop the resuscitation or proceed the resuscitation?
All ethical questions do not have a right or wrong answer. So we have to go in a via media fashion. If we have adequate time, we need to counsel the parents in depth about like the pros and cons in a periviable baby or a baby who do not have any hope. If there is no hope or no purpose, we can counsel, and with accordance to the parents, we might kind of decide not to resuscitate at all. Say, for example, there is a severe congenital malformations and baby is more likely to die and there is no hope or no purpose, then we could counsel accordingly. But if we do not know exactly, like whether if the prognosis is uncertain, and after counseling the parents, or if we do not have adequate time to come in terms with the parents, then we have to go for all-out resuscitation and decide at a later stage once we shift the baby to NICU to decide on. As such, like Indian guidelines do not support withdrawal or withholding life supports. So we do not have any laws or legal stand for us to, unlike in abroad countries, UK or developed countries where there are definite guidelines for withholding or withdrawing support. Indian guidelines do not kind of, there is no specific guidelines or legal for us to, withhold. So everything should be in accordance to the parents. We should always try to get the parents with us. If both of us are, conflicting, say for example, a 28-weeker, if the parents are saying, we do not want to resuscitate, we cannot go by the parents' will because they are 28-weeker, they are going to come wriggling and crying. So that is when we need to spend more time with the parents, do all the resuscitation, bring the baby to the unit, and then have a chat with them at a later stage.
Dr. Thiru, why the time frame has changed from 10 minutes to 20 minutes in the coming up? What is the reason behind it?
Okay, sir. This has to do with studies which have shown that there is even at 20 minutes, even if you have no heart rate, there is up to 10 to 15% chance of having a viable child. And some of them, I think about 3 to 5%, I cannot remember the exact number, but I think 3 to 5% having a normal neurological outcome, particularly with cooling. And that's probably the reason why they have made this recommendation about change, about this change from 10 to 20 minutes. Sir.
So with this, I conclude my session, and thank you very much for the IAP Tamil Nadu and all the team, Dr. Balkrishnan, Dr. Vinod, Dr. Uma Maheshwari, Dr. Prakash, and our visionary Joint Secretary Thiru sir.
Thank you, sir. Thank you, sir.
Choosing this very important need of our program in the basic neonatology CME. Thank you once again. And I conclude this session. Over to Dr. Thiru.
Thank you, sir.
Thank you, sir.
Thank you so much, sir.
Thank you very much, sir.
One more question is there. Very important point to consider during resuscitation is to start passive cooling when we are at the point of drugs and cardiac compression. Who will take this question?
Sir, I would take it. Generally, we do not recommend passive cooling because the temperature can go erratic. So cooling has to be done in a very controlled situation. So we at this point we should not go. The temperature should not go up, or it should not become hyperthermic. That is one important aspect one has to take care. But what generally recommended is to bring the baby to the unit, assess the neurology. If the baby is fitting into moderate or severe encephalopathy, then to consider therapeutic hypothermia in a proper controlled environment rather than passive cooling. So there are so many studies where they did therapeutic hypothermia during transport where the temperature has been erratic and the outcomes have not been so good.
Thank you, Uma. Dr. Vinod, you can address this question. What should be the pressure used for suctioning?
So ideally, 80 millimeters of mercury is the ideal suction pressure you are supposed to use. Anything between 80 to 100 can be used, but not more than hundreds.
Practically, the 100 pressure is not much useful. We have to increase more than 100. In reality, I myself found many times. So anything wants to? Okay. There is no queries in the chat box. Now we are delayed by 20 minutes, Dr. Thiru.
So 10 minutes, sir. We are back by 10 minutes. We are supposed to finish at 10 minutes, 6:10, and we have gone up to 6:20 to 12 minutes. I think we're still on track. So I think, thank you very much, sir. I think you have been a wonderful expert for this session. It's nice to have you. And I think we'll move on to the next session with having another stalwart, Dr. T.L. Ratnakumari, who